Looks like the team is ready to go as always at Mount Sinai. Good to see everybody. Tell us what you have, and we're going to go ahead and get started.
All right, Ajay, thank you to with that position, and we appreciate your support and of course your activity with the TCT. So this is now this 3 cases which we are going to show, and this is kind of a new disease. Remember when we started DES, then the DES ISR started, and now engagement of the coronaries post-hour. So we'll have 3 cases. We have all the 1 hour allotted time. If we can do earlier, we can stop it because there's not a complex cases. Because many of the complex cases we know, they do go for CABG and SAVR unless they are extremely or super high risk. So this is the case, basically 73-year-old with the female who presented with progressive dyspnea, known aortic stenosis. Now what happened to guys? My first slide. Already go to the 3rd slide. This is our case or somewhere
we're
else?
seeing the case right now.
Yeah, no, I'm sure they're going a little too fast. I know I asked them to go fast, they went a little too fast. Yeah. Okay. Good. Show the slide now, please.
Perfect.
Okay. So key is, so I'm sure Ajay, that's happening in your practice also, pre-COVID, and of course all the randomized trials which we have been part in the tower, they require angiography beforehand. But since COVID, we started doing majority of the angiogram, unless patient has a known CAD or multiple stents before, we do angiogram on the table. And this is the case after at the time of the tower had a evolute FX. We also know that if patient has a known CAD, we try to avoid putting a evolute valve, knowing that no matter how cusp alignment and you do, it still always remains a difficulty. So this patient had an angiogram at the time of the tower, which was 26 millimeter evolute FX, and patient improved. And at that angiogram was about 60 to 70% mildly calcific lesion in the mid LAD with a normal ejection fraction. The patient did fine. Now, after about a month or so, had been having more shortness of breath. They gave nitrate and beta blocker. Patient could not tolerate beta blocker. And then the question was, they're trying to put ranolazine and others, but nothing. Patient could not tolerate nitrate, could not tolerate beta blocker. And because of symptoms and knowing this background of the angiographic finding that patient has a moderate LAD disease, which I'm just going to show, then we said, let's evaluate this patient. Did not have any stress test. And we know that patient with the 73-year-old, we knew it was a tough. She also has some COPD, but does not require any bronchodilator. So stress test will not be, even pharmacological may not be good. So let's just go knowing the symptoms, and we knew the LAD lesion, bring it to the cath lab and show what we have. Now this is the case. As you can see here, this was our evolute valve. And what we usually say, consider engagement of these coronaries like as if you are in the Bantal. So a smaller catheter. So this is a case, let me introduce my our other colleagues here, Joe Sweeney on the left side, and we have 2 of our fellows on the right side, and and of course the rest of the staff, which are well known. So key is, as soon as you bring the guide wire into the distal part of the prosthesis, pull the wire out, and this is what you usually see in this particular case. So selection wise, the smaller catheter, this is what did you select here? A FL3O. So FL3O, sometimes even you can use Akari, and we'll show in the different types. So basically, once it is there, you don't need to manipulate too much. So idea is then you can wire selectively, and of course FFR wire I will not try, and we did not try that way. We said let's use our regular wire, try to engage, then you can move the catheter, and we have published that also many of these cases will use your guide extents and catheter, and that's what we did. So wire, then the run through, basically the run through wire, as you see here, we try to bring the guide, and this is the lesion actually, not impressive, mid LAD lesion. Calcium, very small spicule, so mild calcium or no calcium. Diagonal looks okay. And the whole question was that are we done in this case, or we proceed? So clearly the plan was the FFR guided PCI. And if we can go to even our appropriate marker, can we show the slide? We always try to go with our OC criteria, one vessel disease. This patient actually because of the medical therapy, did not tolerate. So yes, could have been in that area of the yellow, definitely not the green or the red. So with that note, we did the FFR. So now, Ajay, and you can ask our panelists there, what is the prediction?
Yeah,
What will
that's
be
right.
the FFR in this case?
That's right.
We
Actually,
can go to Floro again.
And
Yeah.
I think it's a great case because, there are often times with TAVR where, the patient, some patients just, their dyspnea persists and you think it's going to get better because the AS was severe and you treat the AS and unfortunately the dyspnea persists and perhaps gets worse. And it sounds like you did all the things to look for other etiologies as well, knowing that, you knew what the lesion looked like in advance. Any thoughts from the panel? I mean, is the physiology going to be positive? Is it going to be negative? Is it positive or negative matter? Is the absolute number what matters? The final thing I'll mention just technically is that, make sure when you do physiology that you actually equalize in the aorta or do good equalization of the wire, because at least 20% of the time, even in studies, there are going to be artifacts induced that actually affect your measurements. So you got to believe the number. Any thoughts, Jennifer, you want to start?
Thanks. Oh, I have to hold. Gosh, that's going to be exhausting. So, I mean, I think it's worth FFRing, right? It's intermediate, hard to say. Whichever I pick, it'll be the other one. So if I say it's negative, it'll be positive. But I would also make sure prior to doing FFR here that I gave nitro, as well as adenosine, if that's why you're doing it, just because this vessel doesn't look fully dilated. I also wonder if there might be a little bridging in there. If it's significant, you're going to PCI, I would image it as well prior.
Yeah, that's
Cool,
great.
guys.
And
You
Samir, I
have
know
to-
because you're itching
Yeah, and
to
actually
move.
very
and there-
important point. No, actually what Jennifer said, Ajay, if you give me, remember what happened here? You are not fully dilated because look at the guide catheter. It is kind of a angio/aortogram.
Yep.
And that is why we did give nitroglycerin. But I'm saying that many times when you are non-selective injection, vessel doesn't look that big. And clearly you can manipulate, can create a little trouble. We say as long as our purpose is done, we were able to put after the run through, we were able to put our FFR wire. We felt that we just leave it still outside and because whole data will be based on the physiological assessment.
And that's a great way to do it because you stabilize the guide with the other wire. Maybe just because I know you're rushing
Right.
to go forward. Show of hands from the panel. Who thinks the physiology is going to be abnormal? 3. Who thinks it's going to be normal? 3. 3. Okay, go ahead.
Yeah.
Let's
All right, let's show you now.
One thing about
Our
physiology
FFR.
here,
Show the camera,
Ajay,
please.
is I'll tell you, it would have been great to do
Show
it
the
before
camera.
the valve replacement.
Okay.
Because this really, in terms of subendocardial ischemia, left ventricular hypertrophy and stuff, and whenever you're doing it here now, I mean, the point of normalizing is great, but I think when people have left ventricular hypertrophy and high LV EDP in these scenarios, then I think adenosine may be limited, and I think I would be anxious to see what is the difference between IFR and FFR in this setting, because there are smaller studies that actually shown that IFR may be more reliable in this setting than a hyperemia-based index.
If you do it before
Absolutely.
you
I
have
think
aortic
before
stenosis
AS, I
also.
would have done that. But this is post, you
Yeah.
can see here 0.72.
And that's resting?
FFR
That's
0.72.
with adenosine, Samin, or was that?
Adenosine, yeah.
Yeah.
And adenosine within 30 seconds.
Yeah.
It took 30 seconds, 0.72.
What's also interesting, and Jennifer knows more about this than anyone because of the bridging situation, is that if you're worried about a bridge versus a lesion, what you actually, for a true lesion, you'll see separation throughout the period of diastole, whereas with a bridge, it tends to be at the
wire
end, they
further.
come together.
Right.
And in this case, it kind of looks like a lesion. You agree, Jen?
I think it looks like a lesion. I just wonder if there's bridging after.
Yeah.
And if they're very close together, you want to know that before you place your stent.
Absolutely. So you're going to go ahead and treat. And Samin, are you going to image this to see where the
Yeah.
distal landing zone is?
Mm-hmm.
I know we have a debate later.
No,
on-
but why is it? I think the wire crisscross here.
Yeah.
So advance a little bit more. So clearly we put a wire in the diagonal to protect. A lot of people will not. And I know that I'm actually quite a bit, let's take the wire out of the
Yep.
side. Good. Go further a little bit. Yeah, leave it there.
Yep.
So our goal was we use a 2.75, the flex tome, and then put a stent 3.0. Not here, a little less. Pull back a little bit. Yeah. Good. I was even thinking to go direct, but I think it's a little modification in this patient, this age.
Yeah,
Definitely a little bit of calcium is there. Yeah. And so I think this whole case basically was more so not for the coronary point of view, more the coronary engagement. And we kept this session. Just keep it there. One more. Here, yeah. Get the stent ready. Yeah.
So that's subtle
So we
maneuver.
felt that this is the show the engagement point, and I know that the first paper for the engagement of the coronaries after the tower, which I mean during the patients of these, which we coronaries, just the simple cath or PCI. We made the strong point with the Jack paper, and we are going to put a stent now. And this is where we said also, go with the left side with the FL, not VL, not FCL or EBU. So a small EBU could be okay. The small EBU 2.5 or 3.0. And we have done this, and now we are putting a stent. And if this looks good, we can, of course, always optimize by doing the IVUS. But this is, I know we'll hear for your debate. This is kind of a simple, straightforward lesion. If I had to do not use the FF or any further imaging, I'll be okay. Because I know the whole question is, do you do IVUS, the imaging in every case, or some simple, straightforward lesion, which are not the complex? Yeah, go up. The not complex that you can just get away with a good angiographic or maybe use a stent boost in some cases.
So, question for you is because you're crossing
Yeah.
over the diagonal, oftentimes folks will hang back the stent at least 6 to 8 millimeters proximal, so you can optimize proximally. It looked like there was probably 2 or 3 millimeters in this case, but was your feeling that the diag wasn't big enough, that you didn't need to do that, or what was?
Yeah, so you are right. So I would say that this case we thought diagonal is just in between size, and we wanted to protect with the wire, but you saw the crisscross of the wire prevented stent from going in. So we just left it at that place. And I think the ideal case here will be now that if we can do the repeat FFR,
Yep.
and that we'll do live. So let's connect it. So this is we did this all on the FFR wire. Let's give a little nitro, and we'll do a repeat FFR and see how things are. Go. Can we use the same one or no? Okay. If we can use the same, I will prefer. And this will be this actually, in my opinion, as you know, they did all the X-rays, and so I wasn't sure that truly that is causing the symptoms, but patient clearly was symptomatic. I think we think because of the FFR positivity, that was likely the symptoms caused by, and we are going to repeat the FFR now.
Samin, it's Bill O'Neill.
Okay.
You know what I do in these cases
Yeah.
where I'm not sure about the symptoms? I just leave the stent balloon inflated for a minute or two to see whether or not you get ST segment changes and whether or not you reproduce the symptoms, because sometimes that can be very helpful.
Yeah, and I think there are people who would say that, that while the FFR was abnormal, it's not so abnormal that it's going to cause profound dyspnea. So I personally wouldn't be surprised if the patient still has some residual symptoms, but I certainly wouldn't equivocate when telling the patient about the result. I would tell the patient, we got a phenomenal
Okay,
result.
we have to
profound
equalize
lesion,
the
et cetera.
first,
Yep.
right?
Yep.
Let's equalize first. So that's a good point. So to leave it there, the question is, during procedure, we give so much anesthesia because of live relay. There are totally, very rarely you'll see any symptom. But a very good point. When there's a question about the symptoms, that leaving a little longer and try to elicit the symptoms. So we are equalizing now. We have hemodynamics, good. Okay, let's go. Start the drug, please, again. The wire has been a little bent. Came back, will be tough.
Yeah.
No, now will be tough. Yeah, this flimsy wire.
Yeah.
It's good. It's June, so the fellows can they get too coddled earlier in the year with new wires. So this allows them to.
There's nothing there. That's the
Right.
problem.
Okay.
Let me move it a little bit.
Yeah, there it is.
Good. Okay. Yeah. Can we no a little bit manipulate? We can't even ask for the deep breath. But they're ready in room 2 or 3. Where they're ready? Do we know?
Nice job.
Yeah.
Just because you said
Great
room
job.
2 that it went down. But the question I have,
Yeah.
which wire is this?
So it's the same we're using for the
But
Abbott, right?
Yeah.
Boston.
This is the Boston wire.
Boston wire. Yep.
Yeah.
And then good. Yeah. Edison has been started, and FFR, you're seeing it. We are already on to a 32 second, and it's still 9.6. We can wait till full 1 minute.
And you're doing IV
we
adenosine,
s-
correct? IV?
Yeah,
IV peripheral.
IV, yep, IV going nicely.
Actually, we're
But-
central.
But central. You know, during procedure, we always leave about a venous sheath, most of them, although this case didn't need it. And with the 1 minute, I think if it's okay, we are going to pull it now to make
Yeah.
sure that this was clearly,
You have some
There.
separation there, so you'll see what the number
Yeah.
is.
Yeah.
Yep, it's right
yeah,
at the stent.
and other full.
Back to one.
All right. So if everybody's okay, the intervention has been done.
the
Engagement
number?
nice through the core valve for evolute effects and good angiographic results with a negative FFR, and likely patient symptoms were from this intermediate ischemia producing lesion of the LAD. And if everybody okay, I think Dr. Keeney is ready in room 2.
We'll move on. You know, it's interesting because
Okay, thank you,
studies
thank
like
you.
Define GPS are actually looking at whether you need to further optimize and really reduce that separation with post-PCI physiology, but that study's ongoing and enrolling right now, so we'll see. Anu, we can see you. Welcome, and I know this area of through TAVR is dear to your heart because you were, you know, all over and in charge of that paper that was really, really important that came out. So show us what you have.
Yeah. Good afternoon, everybody, and Ajay, welcome. So this is case number 7, if you can see. Is an 85-year-old male who had in post-TAVR, had a 29 millimeter SAPIEN valve, a little different valve, and I think they are going to show you the animation. I know we had written the paper saying which kind of catheters to be used in this kind of situations. I think Dr. Sharma already mentioned that you got to go smaller size because the anatomy changes. Now you have you know, like a metal cage right in front, especially when you're self-expanding. So you can see the animation, how exactly to engage this the coronaries after we do the TAVR. So this is SAPIEN, and the coronaries way above was way, easier. So you can see the right coronary artery, which was non-obstructive. You can see that, right? And we use a VL, the usual VL catheter for the left main. So in the caudal view, you don't see a lot of disease. This is non-obstructive. And this is where I think you can see the distal left main, exactly the case we did before lunch. There you have LAD, we are not sure it is 111 or 011 or I think 100. We think it is 100, but I know everybody will tell us you have to image. So let's see what the moderator as well as the faculty says, and then we move on.
And what do
We
folks
lost them?
think? Yeah, sorry. What do folks think?
We agree, image.
Every image? No, who wants to do it without imaging? Nobody is bold enough to say that they would. I know Nitin wouldn't image, but that's a different issue. So everybody wants to image. So wire, image, see what it looks like, and then come up with a strategy. I do think, though, I mean, it's good to have a strategy before you do the imaging, and certainly the setup is important because occasionally imaging catheters are not benign. I think that's really important. There are times when the left main is really tight and people perseverate and they put the IVUS down and they're looking at measurements and the patient's STs are dropping and nobody's looking at the hemodynamics. That's not the way to do these cases. This doesn't look that tight, but always want to be prepared in advance.
But the question
Yeah,
is,
100% agree. That so what
probably
we were thinking just by angiography, we probably circumflex looks okay. That we should stent across from left main to LAD, and wiring the circ is left up to the discretion of the operator.
Yeah, one thing that I'd like to see is how the anatomy looked before the TAVR, because we usually have an angiogram. And is this something stable or this is something that has progressed?
You have it, right?
That's
We have
true also
angiogram
for
in the
the other
slides.
case.
Okay, if you can go back to the slide, I have it here. Go back to the slide. Now, this is how it was before the TAVR.
Yeah, it looks
Cardiovascular.
worse back then,
Leo
to be
Cardiovascular.
honest. But
The question is why this was not treated before, and now why do you feel compelled to treat it?
So I
85
think
years old
what has
guy.
happened since COVID, patients who are especially elderly and have difficulty in coming for multiple tests to the hospital for multiple times because they need a CT scan. Some people
Yeah.
need carotid based on their and heart team discussion, meet multiple doctors. We have been doing at least 30% of the cases cath on the table. So this is one of those cases where we saw cath on the table. In that situation, unless it is 95% lesion, we would not intervene at that time. We would just finish the tower and bring them back like we have done in this case and even that the other case that was shown. This patient belonged to that case. But if it was done beforehand and we knew that there is CAD, this guy was, at least we know, extreme risk, would have taken care of the CAD first and then done the tower.
Yeah, I think Ron's
So we
point-
can show the imaging.
Yeah, we should show the image. Ron's point is, I guess, that if it's moderate left main and he's 80-something, could you perhaps not treat this? I mean, obviously, the left main is prognostically significant, but that's why the imaging is very helpful, because the cross-sectional area should hopefully allow you to make that decision. And if it's fine, then of course, or if it's borderline, you could leave it too. So let's see what it looked like.
So we are showing left main to LED.
Yeah, we did iris. Okay, I do the pullback. This is from the mid LED. Now it's coming back. Here's a good lumen. Some eccentric plaque, some calcium, like 2 column calcium. Lumens are okay. This is also eccentric plaque. Now come to the circ. And this is distal left main. And body is fine. And I will show you the area.
Yeah, so it looks like
So this is just a
osteo-LED.
distal left main.
Yeah.
Yeah, distal left main like around 5. And this is just an osteo LED, like eccentric plaque and LED 2.8. So by IVUS looks both tight. Distal left main, the osteo LED is tight.
Yeah,
And
I
the calcium is just 2 quadrant. That's the IVUS moment LED.
Yeah, I mean, it also shows you that it's going to be very, very difficult to treat the LED alone without involving the left main. I mean, if the left main was 5 alone, you could, argue either way. But with that LED, I think your strategy makes sense. Did you do a pullback from the circ as well, or you didn't wire it yet?
Yes, we did.
No, we did wire. We have a pullback.
So I will show you the pullback from the circ. This is the mid circ. Not so much plaque. Big vessel. Yeah, some plaque. This is a bifurcation. Of course, distal left main is tight. And a body. And I will show you the osteo circ. Like areas, I think, okay. There's a plaque, but the area is 5-0. The osteo circ.
So what, on the panel, anyone want to say definitively, does this help? Did it not help? What's your strategy? Jazz?
Yeah, no, I think this really helps. I see when you're doing a bifurcation like this left main, 2 things. One, OCT with 3D reconstruction actually can show you the circ very well. So you don't have to do both limbs. But with IVUS, it is mandatory to do both because you overestimate the area when you just do one vessel only. So this is very important point. So that's why they did it. And I think the lumen looks good, but I wouldn't be, fooled by the lumen because calcium is your enemy. How you shift the carina of the left main LED calcium into the ostium of the circumflex is a problem. So I would protect that for sure. Have a wire in there or balloon or whatever it is. We don't have to treat it, but I would be very careful because that calcium can break and go into the ostium of the circumflex.
So Anu, what are you planning? What are your thoughts? I mean, it seems like your original strategy makes the most sense. The question is, do you want to modify it with like a cutting balloon or something beforehand or not?
I mean,
do
with that
lithotripsy.
kind of, I agree with Jazz that, just because the lumen is big does not mean anything, that once we dilate the left main to LED, things could change. But I think still taking into account 85-year-old, I would not do anything. I will leave a wire there and dilate the left main to LED and stent across. Only question is, it's 2-quadrant calcium. Is there anything else people would want to do, or we can just do a cutting balloon, stent across?
I think you can do balloon alone. It doesn't look like full circumferential. I'm very impressed
Okay.
by the lesion.
3.5.
in the ostial
3.5 cutter.
LED.
3.5, okay.
But I
3.5
think
cutter.
if you do pre-deal vessel preparation with cutting balloon, you should be okay.
Yeah.
Yeah, the quadrant is not much, but thickness is there. I don't know. With his left main, I would probably do lithotripsy. Because we are spoiled now, so whenever you see calcium, we do lithotripsy. But I think the
The
thickness.
cash register just went ching. So, but, no,
No,
actually-
there is another option. You can do open and see balloon. It just enter into the market. You can go 35 atmosphere. It's give you very good results. At least by OCT, you have good images. So
But,
that's,
but you know, the truth is, we don't really know, and we actually don't know if an NC balloon alone would do the trick.
Hmm?
I will tell you that we'll be launching a trial not too long from now,
Yes,
looking
sir.
at cutting balloon versus IVL for this exact type of lesion. So hope folks want to participate in that study. But we just don't know. And yeah, but I think that some modification, and we would in our lab, after doing this modification, we would re-image to be sure that we've expanded the lumen, we have a good
6,
fracture
8,
and all of that.
10,
This
12,
case, I don't think there's going to be an issue, but
14,
we would
18.
deploy the same
18.
approach. Anybody?
I think it's a good
Done.
expansion. Everybody agrees? This is a
Agreed.
3-5?
3-5.
How high do you go up? Because we have Antonio sitting in the audience here, and Antonio will tell us we typically go higher. He goes higher than most people in the United States. So how high did you go up?
18.
Yeah. With this one, we went up to 18. Yeah.
He approves. Yeah, at least 18. But I think that's important, and also you want to stay up a little bit to allow the tomes to kind of do their thing and focus the force.
Yeah. And other thing also is come back to the guide and, change the blade orientation, go back and do one more cutting. Good. So after this, we'll go back to caudal view and take a picture to see how the circumflex is behaving. It
And-
looks the same.
And the hemodynamics look
proceed with
totally rock
stenting.
solid, stable. Bill, I mean, left mains, when do you need to use support? When do you not need to use support?
You don't need to use support in this patient. His ventricular function is normal, and you're going to be doing rapid inflation deflation. So I think it could be easily done without support.
Yeah, I mean, this is,
Okay, ready?
Excel didn't have AS, but in the Excel trial, the rate of hemodynamic support
But I
was
think
under
the point
5%.
about when you do these, sometimes you have to consider how tight your valve is going into this before you start on, especially if you have to debulk anything in a complex left main. So that AS, when do you do it and when do you put a valve in sometimes?
thing which would be nice is to do imaging after the cutting balloon, because sometimes we think that we did the job and you may be surprised that we're not, or at least you can see how much break do you have in the calcium.
Yeah, and sometimes with the way the carinal
Ivis.
plaque is,
Ivis.
by opening it, you shift things away and the circ may get better. Other times the circ may look worse. And so it may help you because before you stent across it, that's the one downside of the provisional approach is that the side branch
Yeah.
can be compromised.
Looks like you have a big gutter, like you've done rotoblader into the thing. Looks like a pretty bad dissection in the
Yeah,
distal
yeah,
left main.
yeah. So if you see this, I'm going back because definitely like Jats mentioned, there is a gutter creation. This was how the pre was, you see here. And now after just doing the balloon of the left main to LAD, this is what we see.
Yeah, it looks like the artery is grown so much, but it's a bad gutter with the dissection actually going towards the circumflex.
So let's
But
see
I
what it
still
looks
think
like.
since we did not touch the circumflex,
may be
just
fine.
stenting across, we should be okay.
I agree on it.
I'm a little contrarian on this, but I think that if you stent across a wire, that you're more likely to get
Okay,
an
we are-
infection. So I would usually.
Go
when I
live
do
with
this,
IVUS
do
again?
2 balloons or just balloon without a wire.
Yeah, once again.
You're saying for the pre-dill, Bill.
Pull
Yeah,
back.
because
Okay,
it
start
can
back.
cause a dissection of the side branch, which is I think what
It's coming.
happened here.
So here,
This
this
is
is from
osteo. This is
this is from the LED.
There was a scoring balloon that was
Yes,
based on
yep,
this
LED.
concept that you
Yeah,
have
it's
to
a distal
balance
left main.
on the balloon and creating more.
yeah,
damage.
some plaque modification. Yeah, much
And we
better.
try to
movement.
use it to our advantage. right?
See, pretty bad intimal tear going towards the adventitia. You see it, you guys can show it to the audience.
Yeah, so this is a like hematoma.
Yeah.
Yeah, but we should cover this this left main
Yeah,
lesion.
you're going to cover it proximally. But the question is, what does the ostium of the circ look like? So if you want to, I mean, it'd be
That-
nice to IVUS that, but I would
Yeah.
understand if you didn't. I don't know if you need to, but
Yeah, for-
You're good, but you should probably keep a wire when you stand the left main
Yeah.
to the LED to
Yeah,
the left main.
I think we should not IVUS, Ajay, let's just stand
that's
the left
fine.
main
It's
Sure.
fine.
with the,
You'll
yeah,
extend
and
the
then
gutter
let's
into
see
the
how it
step,
behaves.
so-
Yeah, 4016 or 20?
yeah, but anyway, good plaque modification.
Good
20.
plaque modification,
Yeah.
right?
Very
Okay,
good.
give us a 4 or 20.
Promise.
Romans.
Yeah, we can put follow.
You know, Anu, I'll
It's
tell you
huge.
anecdotally, my son's now 19, but during one of these conferences a long time ago, I think I saw Samin on a panel, and he was talking about deep cuts. And I loved it so much that I went home and talked to my son about it. And last week, doing something random, my son texted me all caps, deep cuts. So it's just, it really, I don't know, he must have somehow learned it. I don't know how, but.
Deep cuts during cutting balloon.
No, usually during, some sort of atherectomy, but you can get it with a cutting balloon.
Ah,
Some of those lesions, you should do also combination devices like the Rotacut. I go back to the open NC with cutting balloon. I've seen images by OCT that were very impressive.
some die here.
And maybe even high pressure with cutting
Really?
balloon. So
Yeah, go Crane.
device combination can be also get you a better preparation.
So this one, you definitely want to be hanging back at least 6 to 8 into the left main so you can do the pod.
Yeah,
Because there's going
so
to be
we can-
size mismatch
yes,
here.
some
So
die, yeah.
just in comparison to the prior
Yeah,
case
Tony?
where the side branch was a lot smaller.
Good, right?
Yeah.
Okay, go up. Okay, we're going up. This is a 4-row, 12 atmospheres. And then we will take a 4, 5, 8 millimeter.
Yeah. 4, 5, 8.
We'll do the pot and then we'll IVUS again.
Yep.
Yep.
Okay, now take a picture, Chris.
Ready?
Flow is good. Hard to see what the ostomy circ is in this view, but I think it'll be all right.
Can we see an LO caudal?
We will.
Question to you, with respect to doing procedure before TAVR or after TAVR. Here, there was selection to do S3, so you don't have any issues in engagement. But how do you feel if you have aortic stenosis before the TAVR to deal with that left main lesion like that? What would be your selection to do before or after the TAVR?
The
looks pretty good,
scientific-
I have
the
to say.
Scientific database
I mean, there
is
is
all
that-
established on no coronary
Haziness,
disease.
but
All the trials are done in patients.
I
without
think
coronary
we should leave that alone,
yeah, I agree.
right? Yes, yeah, give me the thing. 4, 5.
4, 5, 8.
So we're just going to do proximal optimization and then IVUS. Then you can go to the next case is also
BAVM.
another case of post-tower. You're ready, okay. We're
Maybe
just
I'll
going to do.
ask the
SS.
panel, who would want to go back, recross, and do a kissing balloon inflation on the panel? Nobody? Nobody?
Well, I mean, there is controversy in terms of when you do these bifurcations in the left main, when you do provisional, whether you go and open the side struts into the circumflex or no. I would probably, you have the section, you have normal
Right.
flow, I'd probably not to start messing around in there with
Yeah,
wires
perfect.
and
Go.
stuff. But in general, if I saw a big circumflex like this, and here the angle is unfavorable, I usually go through the side branch and open
18.
up the stent struts.
I think the thing we were
Down.
concerned about when you saw your angiogram and your cranial view, you saw the dissection flap, and it's just a
Go up
big
here.
dissection flap
No,
that
don't
came
go there.
down
Can-
and made the image of the circumflex before you stented look like the
Down.
dissection
Yeah,
went that
Divers.
way. After you stented it, you can see that the whole thing
think we are
flipped
good
back
here.
up, and
Yeah.
it looks very, very similar. So I think that LEO cranial view was very helpful to see that double shadow of the original dissection really staying within the left main and going into the LAD.
And the IVUS will show you. I mean, you can see the circosteum here when you pull back. We'll see what it looks like.
It's a little harder, I think. Certainly OCT is better for that, as you said. John, do you have a question? So let's see. And, in terms of setup, I can see, I was working with the 7 French guide. That tends to be my setup as well for left main, just because if during the pre-dill something happens to the origin of the circ and you need to rapidly deploy 2 stents, it's going to be very hard to do that with the adequate sizes through a 6 French system. It can be done, but it's harder.
Change IVUS
That's
on the
generally
screen.
why if
Go
you're
live.
going to go radial, 7 slender is kind of the standard. That way, you can easily do it through a 6, but I think it just gives you a little bit of margin of safety.
Okay, start with work.
Yeah, and then the
These are
sheetless
native,
guides
these are
very,
native.
very important also.
It's coming.
I've been doing now sheetless guides
Dame
to
blanche.
the impeller as a, single access thing, which is a 5 French hole. You can actually manipulate that from the groin. You can manipulate it very, very nicely. So I would,
Concentric lock.
the
Yeah,
7.5
good landing
French,
zone.
So distal
sheetless
landing
Very
is
excited.
good.
No dissection.
Yeah.
Very excited.
I like it. I like the excitement. That's good.
Yeah,
Yes.
this is the bifurcation.
That's at the level of the circ.
Yeah, this is the distal left main.
Yeah.
Very expanded, cover the dissection. Very expanded. Perfect.
Yes. Looks
Nice.
beautiful.
That looks
Nice.
great.
Normal
That
position.
looks great.
I think if everybody agrees, we will just remove the wire, take a nice final picture, and move on to the third case of this session. Ajay,
Yeah,
what do you
for
think?
sure. Let's pull it, see what it looks like, and
Good?
Yeah.
Ready?
Yep.
looks like the guide came
That
out.
was only my problem. Yeah, the
Yeah.
guide, what happened is, okay,
There it
good.
goes. There
Ready?
it goes.
Yeah.
Actually, circ looks better after we took out the wire.
Yeah, there's still that haziness there, but it looks, I mean, the flow's fine. No STs, I take it, and patient's doing all right. I mean, there's a small chance of having an issue. That's why you keep the patient in the holding area and you watch and that kind of thing. But to go after it and then dissect it further and then have to stent it, I don't think you'd be helping the patient a whole lot.
I mean, looks beautiful.
That's great. Thanks, a great demonstration.
Thank you. No, man.
This session is about TAVR and angiogram or PCI, and I would say that I would also pick up here in Edwards because I want to be below, because not all the evolute, it's easy to engage, even if you're doing commissural alignment. We found out that sometimes it's still very difficult. It's almost like, I wouldn't say 50-50, but it's not guaranteed that you do commissural
You're definitely
alignment.
rolling the dice. You're rolling the
Able to
dice.
do it. So I think in this case, it was very wise to choose the Edwards because you know you're not going to have any issue. In the case of the FX, luckily it was done easily, but it's not necessarily all the time.
All right, so I mean, we're back with you.
Okay, good. And actually, the point I would say that Ron made it that although the guy who was the commissioner alignment, Gilbert Tang from Sinai, and we actually had a case last year, excellent alignment, took 3 hours to engage the right coronary artery, 3 hours. So as Ron said, it's a kind of not every case we can do. Actually, the third case which was supposed to be the Evolute case was delayed in the traffic, but that will be ready later if we have time we can show. But I have another third, this one Sapien, but again, Sapien is a no-brainer in the terms of coronary engagement. This case also, we can show the slide number 12. So compared to the slide supposed to be 7, we went ahead and we are showing the backup case, slide number 12. Nope, slide number 12, please. We should have informed them that we are showing slide number 12. So this is a patient, a 74-year-old, and the patient has the tower done all in April, Sapien valve, and that time actually we did the angiogram, same. The cath was done at the same time and found a significant lesion in the LAD. Patient had a stent long time ago and moderate lesion in the PDA, and we'll show the angiogram. And my team here, Amit Huda, and my 2 fellows, Richard and Gennaro here, and our both Ashley and Vicky, and now Jason. So this is clearly same. I would say that when I said for Evolute, you go to a small size. With a Sapien, you go regular size. It's rarely, it's always above, but key is let the wire prolapse into the left sinus, advance your catheter, pull back the wire. Now, because you may still need a little manipulation, leave the wire in the guide catheter. A lot of people will take the wire out, or now your guide catheter folded in, and now you have to reopen it again. No. So leave the wire proximally. I mean, your your basically Teflon wire, 35, pull back, let it engage, and then you take out your wire. So key is the engagement is important in this particular case. C minus, before I came in, Amit engaged it. It is what catheter is it? Tell us now.
This is the 6 French VL35.
Yeah, 6 French VL35 that we would have used. Now, if this would have been Evolute, I would have gone with the 6 French VL30. Now, as you know, the VL catheters are of the Boston Scientific. We use them. All our PCI done with that. Large region is, they're softer, but they got very little trauma traumatic or dissections of the vessel. So therefore, we prefer those. We do carry Medtronic launchers and so little stiffer, but that is what we have been using in our lab. This is the ways you can see a calcium left main is good, circ is good, and then next view, which is the important. You see a part of the stent. Stent was placed a long time ago. And unknown type, they say many years ago, probably was a bare metal stent. And now a small diagonal. There is a second diagonal which almost gone, subtotal, although long. We said leave that alone. And the tight lesion proximally. So this is the case. We had a plan. Now, initially, same. When I did this case, I recommended patient should get the PCI. So just because of, of course, this patient actually had the symptoms, but did fine. But then start having symptoms again. So they did a stress test. So rare that we will bring those patients. So this case, the private physician was not sure what the reason is. They did a stress thallium and patient has a significantly positive ischemia. So this is post-tower, got the stress test and has come here for this vessel intervention. And they have done the IVUS. We can play the IVUS and then you can have a discussion with the panelist. What else should be done? Show the IVUS now. Okay.
Sure. So I start Vivek.
Yeah, IVUS of the LAD.
Yeah, this is a native part.
It's a very long
The-
lesion.
okay,
I think
lumen.
that's why the stress test was,
Yeah,
of course, going to be positive, but yeah.
Okay, this is the all distal edge of the stent. Here is patent, not so much neo-intima. Stent is expanded.
Yeah,
Now,
although
neo-intima start.
it looks a little small in that distal zone, and angiographically you can see that
Yeah,
too.
this is concentric neo-intima, but looks all stent is expanded. And here the calcium start. This is calcium inside a stent. So neoatherosclerosis with calcium.
Beautiful case.
Yeah.
Neoatherosclerosis in the intimal little intimal hyperplasia, but
Now come to the
neoatherosclerosis
ostium.
and circular calcium. Show that circle calcium within the stent.
Sure.
So angiographically, we also see this about 300 plus degree right there of significant calcium. And now question is, the lumen is still about 2 point plus. And this is the case, compared to our algorithm, you do ROTA IVL in almost 50% of cases. This is the kind of case. I think we can go with IVL directly. And of course, now that you can have now, Ajay, discussion with the panelists, what they will do, and we'll continue our part.
Yeah,
Because I want to finish it at 3 o'clock. Yeah.
No, it's perfect timing. I'll ask the panelists. It's a very interesting lesion because you can see how big the LAD is distally. But I mean, you got concentric calcification. The lumen is huge. So if you rota, you need a 2.0 plus burr if you're going to do it. Some would argue that's a role for CSI because you're going to get somewhat in orbit, but it's still going to only give 175-ish or so. So IVL makes sense, or you could try NC balloon. So what do folks on the panel think? John or Sanjeev, what do you think? No, I know, but I'm asking them.
It's a very interesting
Guide
lesion
out.
to get that calcium within the stent in circumference. I've just never seen it, so that's.
No, but if you
different.
image these old stents, the calcified
Full budget.
neoatherosclerosis definitely clearly
Yeah,
happens.
but
Go
But a
ahead.
little more.
not that significant and round.
Yeah,
Anyway,
go off.
I
Go
think
off.
I'd start with an NC balloon and just see if it expands, and if not, then go to shockwave.
Yeah, IVL is the first choice, or 175 or 2 bar.
Jennifer, what do you think?
Well, I was going to say the stent, the stent looks underexpanded originally, right? It's much smaller than the distal vessel. Imaging was very important here.
Good.
I would do IVL as
Go
well.
advance.
I just want to also point out the diag, right? So you have a CTO of that diag, probably at least moderate size. You're going to kind of close off any opportunity to open it, which probably people don't care, but
Yeah.
it's always a moment to
Yeah.
take a pause and decide, I want to just forget that thing before you put a stent across. And although it looks like they're already.
No, actually, very good point. So I think if it could have been a little easier case and a bigger vessel, I probably would have thought about opening. But I think in this particular case, taking a whole equation on a 75-year-old patient, I think it will be reasonable that why to go after, because then you put a stent, then you have to go back again with a kissing balloon. And we know that. Everybody knows, go up again. That kissing balloon, anytime you do, and everybody remember, I'm sure in their practice, the patient come back with restenosis exactly at that area where we went to the side branch and did the kissing balloon, because no matter how we say, we do destroy the polymer, the stent, the drug elution in that area. Very common. So question is, if there is a worth it, probably. If not, I think you leave it alone. So that way our plan is that this subtotal to total diagonal, come back in the guide. Yeah. Let's see.
The other thing with this case is that, with an IVL-based
Beautiful.
approach,
Wow.
you have to
Wow.
deal
Look
with
at that.
your pulse management. And so if you start with IVL up front as opposed to going with regular balloons up front, you may not know how far to wait to be in one area, and you may have to use more than one balloon. So going up with an NC first to C and then using IVL as needed is a reasonable approach, in my opinion. So what size balloon was that,
Yeah, the
Sameer?
3 point. It was 3.5 IVL.
Oh, that was IVL, okay.
So we get ready to put a stent.
And you used up all your
put a stent?
pulses?
You're happy?
Yep. No, about 30. We use 50 pulses.
3, 5, 20.
So I think it looks so good. So I think we just put a stent directly.
Did we image it?
I would image
You
it
agree?
first. I would image it first. Just-
Oi,
It's very
ay,
important
ay,
because there are two
all right.
types of under
I can tell you, artery will get IVUS toxicity.
No, but
not
but
toxicity, but
I mean, the only reason not to image is because you perhaps want to rota out a
He wants to do the
underexpanded
IVL,
stent.
so.
Because I mean, why would
Okay.
you not image to be sure that you have expanded first? Like, there's nothing wrong
Okay.
with doing
There are two
it.
reasons to have underexpansion. One is that up front, when this was done, it was underexpanded because of calcium behind the stent. And the other
Yes.
option is that the
Yes.
tissue and the restenosis push the stent and there's a recoil. So these are two different mechanisms. If it was not expanded in the first place because of calcium, then most likely you will need the IVL because nothing else will expand it.
But you have 30 pulses still left on your IVL balloon. If you go in and you notice
you
that
need.
there's still areas of underexpansion, you use the rest
Good,
of the
fine.
30 and
Yeah.
you're fine. And this took
Okay.
what, like
Yep.
45 seconds?
But I think if you have full balloon inflation, you're seeing that you have
Yeah.
adequate.
Can you show the IVUS on the
expansion, then
screen?
You can theorize that it is recoil.
In a single view,
Okay,
of
start
full
to
balloon
work.
inflation with a low radiation system is
It's
not
coming.
as reassuring as we think it should be.
I would have IVUS more distally as well. I think the
Still native.
vessel is much
Yeah,
larger
this is all
than
edge of the
we're
stent.
getting the impression of by starting so proximally.
Yeah, this looks like an old polymer stent, which has positive remodeling also.
The
There's a
lesion
lot of
start.
positive
Yeah, all the
remodeling,
is expanded.
distally.
It looks much better.
Yep.
Way better.
Now the calcified lesion start, but much bigger lumen.
Look at that. Calcium is gone. Look at that. Whoa.
Some disruption.
There's a little
Yeah, some
dissection
dissection.
inside the
That's
stent,
all right,
yeah.
though, but the
Yeah,
expansion
wow.
is
is good.
And I
Balloon
confirm the
effect.
oral stent is expanded.
Good. So what
Yeah.
is the stent? 3.5?
1 second.
We put a 3.5, 23 Zions. What do you think?
Yeah,
Huh?
you can, measure your length,
Okay,
get
stop.
it right, and the patient's coming back.
We'll leave that angle mild disease after the first septal alone. We just do a proximal 3.5, 23 guy. And now let me ask you again. I do the stent. You will ask me to do IVUS again?
100%.
So
You
Oh,
bought
yeah,
the
yeah.
catheter already. You bought it. It's still working as far as I know. It's still free because you bought it. So why wouldn't you?
But what if the Boston Scientific provided the free IVUS catheter for the symposium?
Then it's
You'll
even
still do
more
it?
free. Then it's even more free. Yeah, but no, I mean the
Oh, I
point.
see, okay.
It
Okay,
restenosed. You want to do a good job,
Yeah.
and for everybody who
Yeah,
says,
no,
why
I
do you
agree,
do
I
it?
agree.
We've all
No,
been
no,
in
but
situations
Ajay,
where there's
actually,
recoil.
I can tell you, I say 80%, that's my opinion, go a little further, that IVUS, to me, imaging, the benefit of imaging, 80-90% is post. So if I had to do, definitely in this particular case, if we start to doing, go a little more inside. Remember? Yeah, good. Go up.
And remember, Zions is mid-marker, so it's actually very nice for
Yeah, good.
trying to nail
Try it out
where you
now.
wanna
Yeah,
be.
but this is stent failure. I mean, if you are
Go up
believer
again.
in imaging or not,
Yeah.
you should not be doing this case without imaging.
Yep.
And pre-imaging is very important to understand the mechanism.
Yep.
And you
Make it,
guys understood
yeah.
the mechanism, that's why you chose the equipment, and that's why you had luminal gain. So I think it's very, very
little,
important.
yeah.
when you have
Do it,
imaging,
atmosphere. Go,
You
go.
gotta finish with the imaging also.
Yeah, and I think also
Good.
most
Like it.
people, if you didn't
Like
image,
it.
and you would never have used the IVL because you wouldn't have known it was concentric calcified neoatherosclerosis.
No, but I can tell you, Ajay, in this case, without imaging, I would have used IVL because proximally you saw that. I'll go back to that. Very calcified. I'll show you
Yeah.
that.
No.
engage.
It looked calcified from the beginning. I agree.
Yeah. So this way, if you see, let me just show. So in this case, in our lab, I mean, again, everybody is different. Look at that. On the top, the calcium level, I don't know whether it project. The calcium is half the size away from the lumen. Severe calcium by our criteria, So this one we would have done IVL anyway. Look at that even proximally.
Samir,
Just
I
to
don't
say,
know.
and this is where we are now.
You don't
Yeah.
think in your lab this would be rotoblader first? 'Cause
No,
I've
this
seen-
case,
I've
because of the
seen this
lumen
at
is
this
reasonable.
conference for a
So
long
this is the
time,
case,
this would
yeah,
be
before
rotoblader.
IVL, I would say before IVL, 100% rotablation. After IVL, this is case like almost 90+% will get the IVL, and we do it only if we cannot get through. So maybe you have to make a lumen if IVL, or you just use a high pressure balloon and then put the IVL. Yeah, with that note, I think exactly at 3 o'clock, if Ajay, you are all right. Huh?
It's perfect timing, great cases. It was
Yeah.
good discussion. We're gonna
Okay.
close and move on.
Good. No, Anu has some point, yeah. Yeah.
We
Yes,
gotta-
Anu.
should we-
Yeah,
did
no,
you do the?
earlier,
Yeah,
Oh,
go.
okay.
Continue. We are doing the IVAS, for last IVAS, yeah. Tell us what you want to say. Yeah.
Yeah, go ahead, Anu.
okay, now when we were doing the earlier case, I think Ron Waxman had a question, right? Which are the cases we think
Good.
we should do, PCI
towers.
before tower, and which we think we can do it
Stop
after
work.
tower? Is that what he was
Sure,
asking?
IBES, sure, thank you.
Correct, that was the
coming.
question. And the answer is?
The answer is same. If there is proximal vessel, and if we think the
So the old stand.
significant disease, more than 90%, we would like to do PCI before. But that case that we did had left
Yeah,
main
now this
disease.
is a new stand.
And like I said, was done cap
Yeah,
of the
exactly
cable,
shape,
just
cut
proceeded.
it.
Now, if that patient, we have had cases where
Good
we
area.
have done stent as well as tower at the same time. We have had cases where left main is 95%. That case has to be done before we pace 180 and place the tower. So we would do the stent first, followed by tower. Now, the other question is, when we
No,
are doing
perfect.
PCI before tower, which cases need BAV followed by PCI at the one sitting before tower, versus don't have to do BAV, just do PCI and bring them. All depends on the gradient. So anybody above 4.5 meters above, and also you look at the echo. If you think the valve is open,
Show the angiogram now.
you
Tell
don't
them.
have to do a BAV at the time of PCI before tower.
Show the angio.
Good, fine, fine.
Oh, yeah.
Good, beautiful.
Nice
Sorry.
job.
Yeah, MSA is the
Very good.
8.5.
Okay, so you show the IVAS now. You saw that fully
We saw it,
expanded
we saw
IVAS, and right on the dot with
Yeah,
the
the
three
position was
IVAS
great.
in one particular case. Maybe we write a case report by Dr.
Yeah, that's
Sharma.
right. That's
three
right.
IVAS in a
Are you
case.
sure you're not in the Columbia lab, Samin?
I know.
All right. Well, great job.
All right.
We'll give you.
Thank you. Thank you. Okay.
It was a little bit crunchy going through. It doesn't look too bad, but